Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12.
You hear a dermatologist talking to a new patient called Karen Patch.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Patch. It's nice to meet you. You were referred by your GP for a problem with your skin. Is that correct?
Yes, that is correct. I told him it was nothing, but he insisted I came to see you. So that's why I made the appointment.
Well, let's see what we have here. Your file says that you have thickened, heavily lined skin on the back of your neck. Do you know how long you have had this problem? Have you noticed any changes recently?
No changes, and I've no idea about how long. I mean, I've worked in the sun my whole life, so who knows when it started.
Do you work outside, Mrs. Patch?
Oh yeah, I work on a farm, and I also like to fish, and in general spend a lot of time outside doing all sorts of activities.
So I can see there is abundant evidence of sun damage on the back of your neck, as well as areas of your cheeks and ears. There is weathering and solar litiginosis, or liver spots, along with several areas of solar keratoses on your hands, which is the rough, patchy skin. The skin on your arms and trunk appears normal.
Yeah, I generally wear long-sleeve shirts, so my arms are protected. I also usually wear a hat when I am working, but I guess it doesn't really protect the back of my neck.
That's good about wearing a long-sleeve shirt, but you need to be careful with the back of your neck. For example, you could wear a bandana. The condition you have is called cutis rhomboidalis nuchae, which is a thickening and weathering of the epidermis, as well as solar elastosis of the underlying dermis. The collagen in your neck has been damaged, as well as the elastic skin.
Is that serious? I mean, it sounds serious.
Well, it is quite common, especially in people who spend a lot of time outside in the sun. In fact, the condition is commonly called farmer's skin or sailor's skin. The good news is that it has no malignant potential, but the bad news is that it does indicate that you are a higher risk for the development of skin cancers caused by sun exposure, such as basal cell carcinoma and melanoma.
Any recommendations going forward?
Because of your increased risk for skin cancer, I recommend that you have yearly skin checks by a qualified dermatology provider.
I can't just put sunscreen on and call it a day? I mean, you said it is not malignant, right?
No, not exactly. Application of sunscreen will prevent worsening of the skin on your neck, and in general, I advise you to protect yourself from the sun, particularly areas with a lot of damage, such as your neck. However, this will not undo the damage that has already been done to your skin during the last several decades. As with any type of cancer, early detection of skin cancer will greatly improve the prognosis and effectiveness of treatment. Skin cancer is more common than many people realize. In fact, 1 out of every 3 cancers diagnosed is a skin cancer. And Australia is the country with the second highest incidence of skin cancer in the world.
Extract 2, questions 13 to 24.
You hear a GP talking to a patient called Seth Kelly.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, it's nice to see you, Mr. Kelly.
Oh, hello. It's nice to see you as well.
So today, it's a routine appointment, so how is everything going, Mr. Kelly?
Not so great.
I'm sorry to hear that. Are you having problems with your stage 5 chronic kidney disease? You were diagnosed 2 years ago, is that correct?
Yeah, that's right. I'm being seen at the Advanced Chronic Kidney Disease Clinic for my renal problems. I recently decided to have hemodialysis. In general, things are going okay with that.
Okay, what about your asthma? Have you experienced any difficulty breathing lately?
No, nothing like that.
So tell me, how are you feeling?
I've been feeling very tired recently, to the point of weariness.
Okay. Any problems with your memory?
No, not that I can think of. The tiredness mostly affects my social life. I just can't bring myself to go to my chess group or go walking with a few neighbours. Also, I have been avoiding everyday activities I used to enjoy, like having a meal with my family.
Mr. Kelly, during the last month, have you often been bothered by feeling down, depressed or hopeless?
Yeah, I would have to say yes. I feel that way frequently.
How long would you say that you have felt bothered?
To be completely honest, ever since I was a teenager. Looking back on it now, my teenage years were filled with frequent periods of emotional abuse. It also sometimes became physical. I often just didn't feel good enough and struggled with trying to fit in with the social groups at school. I often feel very isolated.
I'm sorry to hear that, Mr. Kelly. Based on what you've told me, I'm going to give you some information about depression. Also, I know that the Advanced Chronic Kidney Disease Clinic, where you're being treated, has a psychology department attached. I'm going to refer you to that department for a full psychological assessment.
Okay.
Do you have any questions about depression or possible treatment options?
I don't know. I thought for a long time I needed to see someone, but I just didn't know how to get started.
I understand. It can feel like a big first step. Depending on your assessment, the psychologist will suggest a treatment plan. In the case that it is depression, the treatment plan will likely include cognitive behavioural therapy. This would help you to counter your negative thoughts about yourself.
Would I have to take medication?
You might. We'd have to look at any likely side effects that taking an antidepressant would have, as well as any potential interactions with your existing medication. I want you to know that I'm not just handing you off to the psychologist and backing away. I will be in communication with your team at the kidney clinic throughout this process, and I will follow up with you once the assessment has taken place to go over the proposed treatment plan. Then we will have regular follow-up appointments to monitor the progress of treatment and the side effects of any medications that are prescribed.
Thanks. That means a lot.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear a patient's family member expressing concerns to a nurse.
Now read the question.
Hello, Mrs. Leary. How are you today?
Oh, a bit overwhelmed. As you know, my husband's prognosis is not great, so I've been looking for nursing homes.
I see. That can be very difficult for anyone. Have you received assistance from the social worker?
Yes, but I'm worried about what the hospital has told me. They told me that I have to find a nursing home in the next 2 weeks or he'll have to go home. I just don't think I'm physically capable of providing total care for him. I mean, I see what you do, turning him, positioning him. I just don't know the best place for him.
Have you talked to your husband about his wishes? That should be the most important.
Question 26.
You hear two nurses discussing a patient referred by his GP.
Now read the question.
Have you checked on the new patient that came in last night?
Mr. Solomon, the 49-year-old gentleman who was referred by his GP for shortness of breath.
Yes. Did you notice anything strange about his medical history?
Medical history? No, but I did notice that he recently travelled internationally, which seems to be a key factor. 3 months ago, he took a flight from Los Angeles to Scotland. His GP thought it might have been a viral illness, but the patient didn't improve, so he referred him to the hospital.
Did you notice anything when you checked on him this morning?
Yes, he had peripheral cyanosis, indicating low oxygen levels in his red blood cells. I saw that an echocardiogram was requested, so that should clear things up.
Question 27.
You hear a GP discuss a patient with a radiologist.
Now read the question.
Hey, Dr. Haskell, I have a patient here that I'm thinking of getting radiographs for.
Yes, I saw the file. Is this the 69-year-old gentleman presenting with continued lumbar back pain?
Yes, it's been ongoing for 6 months, worsening per the report of the patient. The patient reports that the pain worsens after significant activity, and also that he gets no relief from paracetamol and only modest relief from NSAIDs. Latest exam was unremarkable and recent lab work was normal, so my next move is to get radiographs.
I agree, especially given the duration and worsening pain. If he had responded to the NSAIDs, it might be...
Question 28.
You hear an intern asking a senior doctor a question after a training session.
Now read the question.
Dr. Norris, I have a question about the case study you presented in today's training session. Do you have a minute?
Yes, of course. Was there anything unclear about the recommendations to reduce the patient's risk of developing future kidney stones?
No, not the recommendations themselves. I understand that the recommendation for all calcium-based stones is to increase fluid intake to maintain urine output, as well as a diet high in calcium and low in sodium. I understand that high urine output dilutes the calcium in the urine, but what's the reason for a diet high in calcium?
I see where you might be confused. A high calcium diet increases the amount of calcium in the gut, which binds to oxalate and prevents the absorption of oxalate and reducing kidney stone recurrences. The idea is to decrease the absorption of oxalate, which is why a low oxalate diet is also.
Question 29.
You hear a GP ask a colleague for advice about a patient.
Now read the question.
Hello, Dr. Jackson. Do you have a minute? I have a patient I'd like to get your input on.
Of course. Tell me about your patient.
I have a 40-year-old woman with no personal or family history of breast or ovarian cancer asking if she needs a mammogram. She's never received a mammogram and based on a self-breast exam has no immediate concerns. I think it would be okay for her to get a mammogram, but...
Well, current guidelines for mammograms indicate that women at average risk between the ages of 40 and 44 can be given the option to start breast cancer screening every year. And then when women reach 45, they should get a mammogram every year. So if your patient wants to be proactive...
Question 30.
You hear an intern in radiology talking with a senior doctor.
Now read the question.
So, let's get started. Can you please present the case to me?
Yes, of course. Here we have a 9-year-old girl with no past medical history presenting with left leg pain. While playing, she jumped off a 2-metre fence and landed on her feet prior to onset of pain. There was no head, pelvic or abdominal injury. In the A&E, she was grimacing and refusing to ambulate. Exam showed pain superior to the medial malleolus with minor ecchymosis and significant localized edema. Here we have the radiograph that was taken.
So, what is the specific diagnosis?
According to what we see here, she has Salter-Harris type 2 fracture of the distal tibia, which is a commonly seen fracture with an excellent prognosis and remodeling capacity.
Is surgical intervention necessary? What is your next step?
In general, no. We would need to get another X-ray, that is the perpendicular plate.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
You hear a researcher being interviewed about a new class of cancer drugs.
You now have 90 seconds to read questions 31 to 36.
Welcome everyone to our programme, Health Now. I am very pleased to have with us here today Dr. Kevin Gallagher, a cancer consultant at the Royal Marsden Hospital. Tell me, Dr. Gallagher, how are you today?
I'm doing quite well, and I'm excited to be here today to share with you a revolutionary new class of cancer drug that can be used to treat a wide range of tumours. It is the first drug of its kind to be approved for use in Europe, so we are excited to talk to the public about it.
That does sound quite exciting. Tell me, Dr. Gallagher, I have heard the term tumour agnostic. What does that mean exactly?
Tumour-agnostic drugs do not care where the cancer is growing in the body, so long as it has a specific genetic abnormality inside. This approach has the potential to cure more patients and cut side effects.
Why is that exactly? How does it know where to find the cancer?
Well, our previous approach was to treat breast cancer or lung cancer, but with this type of medication, we are moving towards precision medicine that can take advantage of the genetic makeup of each patient's tumour instead of targeting an area of the body for treatment. This treatment targets the abnormality and uses biochemical pathways that are common to many different tumour types.
So you said that this is the first drug of its kind approved in Europe? Does that mean that it's available to everyone at this point?
No, not quite yet. The decision of European regulators does not mean it has been made available for all patients in the United Kingdom. First, the NHS will need to ensure that the right genomic testing is available across the country to identify patients who could benefit from the treatment.
Can you give us an example of a case from the UK where this new treatment has been used successfully?
Yes, of course. We recently had a little girl named Charlotte. She was diagnosed with infantile fibrosarcoma, a cancer of the body's connective tissue. Her parents were informed of this new treatment option, and they accepted it in part because they knew that their options were so limited. Now to the more technical part. Charlotte's tumour was caused by a genetic abnormality known as NTRK gene fusion, meaning that one of her DNA accidentally merged with another, and the alteration in the blueprint of her body led to the growth of her cancer. It is worth noting that while this type of gene fusion is quite rare, it is not unique to sarcomas, Charlotte's type of cancer, but it also appears in some brain, kidney, thyroid and other cancers. This means that the same medicine that was successful in this case can be used across a wide range of cancers. Also, it is particularly exciting that we have found a treatment for this particular type of cancer, because when NTRK fusions were first discovered back in the 1980s, there was a widespread fear among researchers that they couldn't be treated with drugs because the NTRK genes play critical roles in the development and survival of nerve cells, which raised the possibility that altering the genes could cause dangerous neurological side effects. Future research has obviously shown that those fears were unfounded.
So how is little Charlotte doing today?
Oh yes, she's doing great. Her parents report that she is busy making up for lost time, and she's now leading a relatively normal life.
How exciting! So can you tell me a bit more about the drug itself? What are the side effects?
Like I mentioned before, the side effects reported during the initial trials included mild fatigue, dizziness and digestive issues. But for the most part, the drug was remarkably well tolerated.
Okay. And what about the effectiveness of the drug? Does it work on all patients?
Well, no drugs work on all patients, but based on data from studies from America and Europe involving patients with NTRK fusions who had run out of treatment options, this drug produced a 75% overall response rate across the range of tumour types that I mentioned earlier. Of those responses, 39% lasted a year or longer. Now, those were studies focusing on adults. Studies focusing on children show that they respond even better, with an overall response rate of 94%. More studies are underway to determine.
Extract 2, questions 37 to 42.
You hear a presentation by a GP on group appointments.
You now have 90 seconds to read questions 37 to 42.
Hello everyone. My name is Maxine Williams and I'm a GP who works at the Parchmont Medical Centre in Surrey, where we have started a new way of seeing patients. This new way involves a GP seeing several patients together in one group session. While this may seem strange at first glance, it is something that we decided to try because of the increase in demand for appointments at our practice. An interesting statistic is that in recent years, the number of GP appointments has risen by about 13%, but GP numbers are up less than 5%, which means that GPs are working more and more hours to see all the patients that need an appointment. Burnout among GPs is a very real problem. Another factor increasing GPs' workload is the fact that many of us are living longer and with multiple long-term health conditions, which can make consultations increasingly more complex. We can say without a doubt that the traditional one-to-one 10-minute appointment no longer works for many of our patients. Without increased funding or a substantially increased GP workforce, primary care teams have to find innovative, new ways of delivering routine care in general practice that simultaneously save time and improve quality, which is what led us to the idea of seeing multiple patients at the same time. I will give you an example of how this might work in the real world. I had a patient who had reached 50 years of age and had a few diagnosed health issues, problems with weight and blood pressure, so it was definitely time for him to come to see me. However, when he came in for an appointment, instead of having the usual 10 minutes with me, he had an hour and a half with a GP. But he didn't see me, the GP, alone. He shared his appointment with 6 other patients who all had weight issues and/or had been diagnosed with pre-diabetes. Group sessions can include as many as 15 participants. Our group sessions start with a doctor's assistant or facilitator collecting the patient's measurements and compiling a list of questions the patients want to ask the doctor. Depending on the group, some test results, such as body mass index, will be written up on a board in the room so that the GP can lead a discussion around them. In the case of the group previously mentioned, I, the GP, also led the group in a discussion of sensitive issues such as gut problems and patients' relationship with food and their overall mental well-being. I think for many of the patients it was the first time that they had had a chance to engage in this type of in-depth conversation with a GP. The objective of the group sessions is to give patients more information about their condition because they can learn from the doctor as well as from each other. This helps to ensure the GP's time is used efficiently, and it also results in patients feeling more empowered. Many people think that it would be constraining to have other people in the room, but that is not what we have found when we have asked patients about their experiences with the group appointments. The patient I mentioned before said it was quite the reverse for him, and that once the group got going, a bond was formed and everybody was quite open. This bond that forms between patients with the same diagnosis is the real strength of the group appointment. Managing long-term health conditions such as obesity and high blood pressure can feel overwhelming for patients, so offering more access to a patient's GP along with a valuable peer support network can bring real benefits in the long run. However, if the idea of discussing your medical condition with a group of strangers still seems off for you, we also continue to offer patients the option of traditional one-to-one appointments if they wish. In addition, one-to-one appointments will still be the first step for patients who don't already have a diagnosis. Diagnosing someone in a group wouldn't be appropriate. Finally, another good reason to continue to offer traditional appointments is for patients who are concerned with confidentiality of their health information.